Hello, welcome to our presentation. Today we are going to talk about Case 6, which describes the operative procedure, laparoscopic sigmoid colectomy with mobilization of the splenic flexure.
Within this presentation, we will review why this procedure was performed. We will go over a quick review of the anatomy of this region this procedure addresses. Then we will go over an overview of this procedure, and finally I want to highlight some of the tools utilized to assist the surgeon.
There are many reasons why a patient may need their sigmoid colon removed, but a few of the indications are patients with diverticulitis and colon polyps. In Case 6, the patient had a large colon polyp on their sigmoid colon. Colon polyps can be pretty dangerous because it can lead to bleeding and even cancer.
As this case is a laparoscopic sigmoid colorectomy, the region we can focus on is the abdominal area. I have two pictures to remind us what organs we can find in the region. The picture on the left gives us a sagittal view, while the picture on the right gives a frontal view. You can see here that the organs such as the liver, stomach, pancreas, and the aorta is within the surgical area along with the small intestines. The colon extends around the right inguinal region up to the right lumbar region, up to the right hypochondriac region, right to the epigastric region, right to the left hypochondriac region, down to the left lumbar region, down into the left inguinal region, and into the hypogastric region. Here you can see how the trocar would be placed into the region to facilitate the surgery.
The sigmoid colectomy is a very complicated procedure. We will not go through every detail in this presentation, but instead we will focus on some of the important concepts. Basically, part or all of the sigmoid colon is removed. Once that is done, the descending colon is then reattached to the rectum, and then the patient is closed up. The entire procedure is done under general anesthesia with the patient in a supine position. To prepare the abdomen for surgery, multiple thin tubes known as trocars are placed in 3 to 5 small incisions in the abdomen. Carbon dioxide gas is then used to inflate the patient's abdomen. A telescope is then placed through one of the incisions in order to visualize the area inside. Specialized instruments are then placed through the trocars in order to perform the surgery. The splenic flexure is the natural bend in between the transverse colon and the descending colon. It is highlighted in the yellow box in the picture on the right. Mobilizing this part means to allow it to be maneuvered out of its place. This is important because it allows the physician to more easily work on the colon. Once the abdomen is prepared and the splenic flexure mobilized, the physician then removes the sigmoid colon. Using specialized stapler, they cut and seal the colon on both ends of the sigmoid section, which are the end of the descending colon and the top of the rectum. Once it is removed, the sigmoid colon is taken to a separate table and dissected and observed to verify the size of the polyp. After the removal of the sigmoid colon, the descending colon and rectum need to be connected in what is called a colorectal anastomosis. In this procedure, a tool called an end-to-end anastomosis stapler is used to connect the both ends together to allow the colon to still function properly. This method has been shown to be more accurate with very low rates of leakage from the connection sites. Once the anastomosis is completed, it is now time to close the patient up. The abdomen is irrigated and cleaned to promote healing and prevent infection. All port sites are closed off with sutures, and all tissues, such as the fascia, are closed using sutures and ointment is applied to them to promote healing. Once all tissues are sutured closed, a clean, sterile dressing is applied to protect the wound from infection.
This was a laparoscopic procedure which used a Husson trocar, which is a blunt trocar that is inserted into the peritoneal cavity after making a small incision. This can be seen in the upper right corner. The hand port, which can be seen in the bottom right corner, is used in a laparoscopic surgery in a hybrid operation that allows the surgeon to introduce his non-dominant hand into the abdominal cavity through the port. Some of the staplers used were the GIA 80, TA60, and the end-to-end anastomosis animal, which are not pictured here. Another tool used in this procedure was a purse stringer, which is a device used for placing purse string sutures. This can be seen in the bottom left corner. In addition to these tools, I want to address colonic tattoos, which were used in this procedure, which are routinely used to facilitate laparoscopic localization of neoplasms. They can be placed via flexible endoscopy in the operation room to mark the distal transaction point.
As discussed in our agenda, we talked about the indications or why this procedure is performed. In our case, it was performed because the patient had a sigmoid colon polyp. We discussed the various tools used in this operation, including trocars, staplers, and sutures. And we went through an overview of the anatomy and what the procedure entails. We hope you have learned something in this presentation. Thank you for watching.